Great. Well, hello everyone. Let's get started for today. My name is Nicholas Franco, and I'm a medical student at the University of Washington. And it's my pleasure to welcome you to the ACP Long COVID Interest Group. And with that, I will let Dr. Chopra introduce our fantastic guest for today.
Thank you, Nick. Welcome, everyone. This is the Long COVID Interest Group, and we are so happy to have you here and happy to introduce our guest for today. I'm so honored that he has given us time. It was really hard to have him commit to this because of his the multiple, roles that he plays. Dr. Michael Brode is the medical director of the post COVID-19 clinic at the University of Texas in Austin. He leads a multidisciplinary team caring for long COVID patients. He has authored numerous papers which have been cited multiple times on long COVID and is considered one of the leading experts in the field, especially from the primary care perspective. Every few months, when we hear from Dr. Broad, there is something new that he's doing. And I know that he's dedicated to empowering primary care physicians with information and education about long COVID. Welcome, Dr. Broad.
Thank you so much for that wonderful introduction. And I would be remiss if I didn't give a shout out to, I am University of Washington trained in internal medicine and primary care. So thank you to the
Oh my
University of Washington
goodness.
too.
Thank you very much. Then we have two reasons to be so proud. Thank you for joining us today, and let's dive into the sort of agenda for today. And I know that you have a wonderful presentation for us, which I'm very excited about. So, Mike, long COVID can present with more than 200 possible symptoms. From your experience, what are some patterns or symptom constellations that primary care physicians should learn to recognize early, especially in patients who don't even know that they have long COVID?
Yes, it's a great question. I'm going to share some slides on this, I think a little bit for my framework and how I approach the illness. I think too, people have questions, please jump in. I have some prepared slides, but I also want to make this conversational. I don't have any disclosures. And I think you're right of, what is long COVID? My actually first experience taking care of patients in the hospital, we really know the acute COVID illness, this kind of viral phase, inflammatory host response. We have evidence-based treatments for each stage of that, but still it's kind of, well, what are the sequelae of COVID-19 if people do not fully recover? And I think, as you referenced, there was at the very beginning, maybe in 2021, there was a race to who could identify the most symptoms, 50, 100. And the paper you referenced actually identified 203. And so it really made it difficult of long COVID is everything and therefore it's nothing. And how do we start to really understand it? I even put up this graphic. This is the NASM definition of long COVID, which I think is an excellent policy document, although still this is a busy summary slide. And so trying to just take a step back and what is the framework of what are the sequelae or health consequences that can happen after a COVID-19 infection? And I think about it in three major categories. The first being end organ damage, direct damage that we can detect on our traditional tests. And that is almost exclusively in people who are hospitalized. And it's what you'd expect: pulmonary fibrosis, post-ICU syndrome, PTSD, usually the result of kind of an ARDS or hospitalization for those who required oxygen during the acute illness. The next category gets a little squishy, but I think is a very important one. And I would characterize that as new or exacerbated chronic conditions or diseases. And it's very clear that the inflammation from COVID-19 increases the risk of developing type 2 diabetes, cardiovascular disease, stroke, overall mortality. But I think another big one that we see a lot clinically is it's pretty clear that it increases the risk of developing a new rheumatologic disorder, or for those people who have these things already. I've seen so many patients where it just accelerates or unmasks that underlying disease process. But once again, we can detect this with our traditional tests and have evidence-based treatments for that. And I think the third category of what I would consider more as long COVID itself is the last group or category of sequelae. Uh, and that is usually a diffuse set of constitutional interrelated symptoms that I kind of have a couple different groups, even within that long COVID. And the first is your typical post-viral symptoms, anosmia, ageusia, headaches, cough, shortness of breath, chest pain, very common in this. But I think the one that gets a lot of people head scratching and is hard if you don't have a lot of experience with this population, especially for PCPs, is what I would call the dysregulated immune response or autonomic symptoms. And so a lot of patients, at least on the autonomic function, having tachycardia, POTS, dysmotility, sensory neuropathy, and maybe the dysregulated immune response, kind of more the mast cell activation phenotype, having urticaria, rash, dizziness, balance, kind of these odd diffuse symptoms. But from my experience, I think a lot of the research we can get into, what seems to be universal amongst this population is most patients, if not all with long COVID, will have some form of fatigue, neurocognitive impairment, which colloquial patients call brain fog, and then post-exertional malaise, that phenomenon of doing a physical, cognitive, or emotional exertion, and it just knocks people out. I think it has been rightly identified over and over that, hey, those are basically the definition of chronic fatigue syndrome, which does have its own strict definition about length and severity, but it is so common in long COVID that it is almost the overlaps of that illness are very similar. And so I think this is my summary slide. And for primary care docs, it gets really hard because these are not exclusive. They can overlap. They can be, people can have different combinations of all these sequelae. But if I had to put it down to, what clinically I am looking for when I'm working up these patients I'm worried about long COVID, I'm looking, is there end organ damage? Usually in people who were hospitalized, have they developed a new or exacerbated a pre-existing chronic condition, or do they have more of this constellation of symptoms for which we cannot identify a clear cause on our testing, which argues more for category 3 long COVID? And so, long COVID isn't everything. I would kind of argue that the big sequelae to look out for is more of a post-ICU syndrome, a new or worsening chronic disease, or what I would define that third category of long COVID is a post-viral chronic fatigue syndrome with or without neuroinflammatory symptoms, which are most predominantly autonomic dysfunction in my experience. And always just, pointing out that it is highly recognized that this is the sequelae of long COVID, but we have known for hundreds of years that this is not unique, that a lot of infectious or viral infections can cause these post-acute chronic conditions. And most of them are characterized by what we're seeing: fatigue, exertional intolerance, neurocognitive dysfunction, and other neurologic symptoms. And so getting a good COVID history is important, but it is not the only discriminating factor of whether they have a post-infectious chronic condition. And so, for the most practical advice I can give to primary care physicians, I think that an interest group, I don't have to convince you if you're joining this, but of course, believing the patient, I think it's just been really satisfying to, I get it, it has been a busy clinic and patients say they have dizziness, they have chest pain, they have all these diffuse pain and worrisome symptoms, but just to step back, let them tell their whole story and kind of hear, are they connected? What is the pattern that patients are seeing? And to let them tell their story instead of kind of forcing my agenda of, okay, chest pain, I got to go through the algorithm. And I do think if you have a concern for long COVID, kind of seeing the aggregate and not losing the forest for the trees during the history, and really providing that validation to the patient that yes, this is an illness. These symptoms are probably connected. But for the next part, we still do not have a discrete diagnostic test. It is a clinical diagnosis, so if they fit the pattern, but still, we should evaluate for alternative etiologies of symptoms. And my two big pearls on that, it's hard to get the research to identify that, but I think in my experience, most patients will report a real clear change in their health following COVID-19 illness, that they had a baseline and then they got sick and worse and had these new symptoms that usually will begin immediately, but at least within 6 to 8 weeks of their acute COVID-19 illness. I think if someone describes, oh, they've had this subacute course, they had a COVID-19 infection 2 years ago, or they were doing fine for 6 months and then they developed these weird symptoms. I can't say for sure it's not long COVID, but that would be an atypical pattern that would really make me work up a lot on the differential and think long COVID more as a diagnosis of exclusion, because there is a pretty, in my experience, that infection is a pretty clear inciting event for the change in their health. And the next one, as I said, that post-exertional malaise, I'll talk about the data supporting that, but really is my experience a cardinal feature. Fatigue, brain fog are pretty non-specific, but if patients describe post-exertional malaise, they go grocery shopping, they write some emails, they have a work deadline, and it just knocks them out for days. That is really makes me think this is likely long COVID. And if they don't have that, once again, I can't say definitively it's not, but I can't tell you how many people had fatigue, brain fog, a little bit of tachycardia, but didn't have post-exertional malaise. And we worked them up really rigorously and found other causes of their illness. So I would say that's a big one to really ask for and strengthens your clinical diagnosis. In addition to the alternative etiology, it kind of goes hand in hand with that. But, if it is based on the predominant symptoms they have, whether it's chest pain, other neuropathic pain, you might do a focused workup to see if we can identify some end organ damage or a new chronic condition that may be triggered or masked by that COVID infection. And of course, trying to be patient-centered as much as possible. I would argue that kind of the neuroinflammatory response of COVID-19 infection causes anxiety, and having long COVID can be depressing. And so, chicken or the egg, I don't care. We should just screen them, treat them with our evidence-based treatments, and make sure with their health-related social needs, they're getting the support they need, because it is hard, navigating a system with a fatiguing illness with cognitive impairment. So we should do our best and go the extra mile for these patients. So a little bit of a long story, but that is my start.
So I think what was so wonderful that you mentioned to look for post-exertional malaise. I think that is a very, important point that I would really like to underline for our primary care physicians. And this is exactly what, it falls in line with the pattern recognition that we often, talk to our peers about. Which is one thing. The other big thing is the presence of dysautonomia and, hypertension, dizziness. And a lot of times that is something where primary care physicians become really confused because they don't know what to do with it. And, I know that you will talk about it in your subsequent slides, but that's something that I used to find very daunting. And only after I went into the started seeing long COVID patients, did I become more, comfortable managing it. So thank you so much for, giving us this very insightful information into how you approach these patients. And over to Nick for the next question.
No problem. So kind of continuing off of those maybe impacts to ADLs and how post-exertional malaise is affecting people's day-to-day lives, are there any tools that you use in order to kind of track these patient-reported outcomes or any validated instruments that you use in your practice?
Yeah, it's a great question. The answer is yes and no. I would say, at least for the mental health comorbidities, it's part of our clinical. Every patient gets it. The PHQ-9, GAT7, PCPTSD. I'll also say, especially with PHQ-9, there's a lot of the somatic symptoms of fatigue, brain fog, that overlap with common long COVID. So, pay attention not just to the score. It's tough. We have a clinical research registry that we have all patients fill out a pretty intensive survey, both about symptoms, their long COVID illness. I think one of the main primary patient reported measures we use is the PROMIS Global 10. And I think that one is great. It asks about fatigue. It has a pain scale. It asks really about functioning. So those are the ones we are using. And I think those are built into our clinical system. We are not routinely using other ones. I do think getting a MOCA or other cognitive screening exam can be really helpful. We'll talk about it a little bit later. Most patients will have some minor deficits or mild cognitive impairment, but if you are seeing something that is really profoundly bad, I think that would make you think maybe something else or in addition is happening to long COVID. The last question, there's some other ones, like the SF30, some larger ones, the Compass 31 focused more on autonomic dysfunction. On the PCP lens, I find that really hard to kind of institute screening. The Compass 31 is 31 questions. But I do think using a validated tool may be really important for someone who is disabled and are needing either workplace accommodations or disability protections. It is all of this in the absence of a diagnostic biomarker is going to be clinical and patient reported, but providing some objective validated measurement of severity and comprehensiveness is a little bit easier to take to a disability employer SSDI and say, like, look, they have severe dysautonomia on this validated scale. And do all insurance companies care? No, but I still think they require objective evidence, and that would be a population that it would really be in their interest to fill out 31 questions.
That is very helpful. I think that's a very practical tip for PCPs, that doing these questionnaires is not only giving them additional information, but also eventually will help them with the SSDI process, because again, that paperwork and that whole disability filing process becomes a huge sort of, mountain that primary care physicians need to cross. And that's a big hesitation for them in accepting these patients too. So thank you for that perspective. And
yeah.
Yeah.
Can I just add on one other thing for PCPs doing the disability paperwork?
Yes.
I think the hardest part is, I will gently say I don't think all of these reviewers act in the best faith or interest of the patients, but they really, as I have been through this through many people, the objective evidence is really the standard they are going through. And so the physical exam is, we don't think about it too much, but I've had so many people say, like, this, I write in my assessment plan, they meet the NASM definition, WHO, like all these more scientific in my assessment, but they're like, oh, but you wrote they're in no acute distress, so therefore they're fine. And I can't tell you how many letters I've received. And so even just writing, like, the patient appears tired, they are oriented but have word finding difficulties, can really I know that doesn't have a huge effect on your clinical impression or communicating amongst providers, but even documenting those small things can matter a lot to the patient's access to the social services they need.
Yes, definitely. Thank you for that. And Mike, I want to switch gears a little bit and talk about some common management strategies that we use in clinical care, especially energy conservation and pacing. what are your go-to ways of explaining these strategies during patients, clinical visits? How do you talk to them about pacing?
Yeah, that is as I describe to the patient, energy management and pacing is the foundation of long COVID recovery that everything else rests on. Um, I'll just, kind of as I reference going back to the science and the data, the large NIH Recover trial, the prospective cohort of almost 14,000 people just shows once again that fatigue and post exertional malaise are consistently the most common symptoms, and they are usually co occurring and interrelated, and being one of the functionally disabling symptoms. As we say, if post exertional malaise on their scoring system gets you 6 points, fatigue only gets you one. But I would say the problem with that is, in the definition, it's an almost universal symptom, but it's non-specific. But you know, fits that clinical pattern. And so this is how I really, in the most practical way, try to explain to patients how I'm going to take them through the steps of treatment, energy management, intentional rehabilitation, which I'll talk about, symptomatic management that usually gets more into the pharmacotherapies, and then the holy grail, the targeted curative therapies, although that all remains experimental and in clinical trials. But really getting into the energy management, how I talk about with patients is, once again, I emphasize that post exertional malaise is fundamental to the illness. And I tell patients of being like, I describe it as a wall that people crash into. And if they overuse that body battery, that energy can come from physical, cognitive, emotional, sensory, or even orthostatic exertion. And if they drain that body battery all the way, they are going to crash and they are going to suffer the physical consequences. Some people call it post-exertional symptom exacerbation. And this used to be one of the, now that there's a little bit more education about long COVID, most patients are coming in with a lingo about post-exertional malaise, but this used to be my most satisfying thing I do, of just explain this crash and recover cycle. I think a lot of patients are just geared to fight, 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 and push through. And what would happen is so many patients would, they would have a work deadline. They would go on a small trip. They would try to exercise and they would hit the wall. They would crash. They'd be in bed for 4 days. And then they'd wake up on the fourth day and be like, okay, I actually feel pretty good. Now I got to go do all the things that I missed for 4 days and make it all up. And so I can't tell you how many patients got in this pattern of they crash, they'd be in bed, they'd recover a little bit. As soon as they felt better, they'd feel start to get a little bit better, and then they crash again. And just kind of explaining that phenomenon, it was, patients' jaws drop. They're like, "Oh my God, how did you know that's me?" Or, their spouse is sitting next to them, nodding along, being like, "Oh my God, that's exactly what's happening." And so it sounds very silly, but we have research data of that post-exertional malaise is actually physiologic damage. We know that on muscle biopsies that there can actually be structural damage to the muscles from post-exertional malaise. So it's not just a symptom, it is a physiologic phenomenon. And as simple as it sounds, as soon as you can convince patients to stop crashing, they will actually stop making themselves feel worse and give their body a chance to recover. And that can be, it's very simple. That counseling can be transformational for patients and how they approach their illness and approach their day-to-day lives. Kind of within that, we do a lot of counseling about how do you manage physical exertion? How do you recognize where your wall is? Are you getting fatigued? Are you having trouble concentrating? Are you feeling tachycardic? And then you just got to rest and back down. Good sleep hygiene to recharge the battery is a really important part of that. And we discuss all those things in detail. The rubric that is really, I think, the easiest one, if you like mnemonics, is the 4 Ps of, we talk about making sure patients prioritize the tasks that they need to do. And I put in that one a lot of work accommodations. It's going to be hard to work a 12-hour shift. It just is. And so usually fewer hours spread out can be helpful. Pacing throughout that, positioning, avoiding orthostatic stress, or um, creating a work environment, which I would even include working from home, can be really helpful. And just planning that they're going to have the wall. I even tell patients, when I can make that post exertional malaise go away, I can make that crumble that wall, I can cure long COVID. And we just don't have that yet. And so you have to plan on that you will have some form of that while you're experiencing long COVID. For some people, the data says that wall goes away and everything else gets better. That's not an insignificant portion of people who are cured with COVID with time, but for a lot of people who experience this as chronic condition, that wall is the main limiting thing. Um, and within that, if people do have a little bit of excess energy that they have to spare, I do think an individualized and structured return to activity program can be really helpful. The most practical resources I like, I don't want to shill for a specific app, but I think the Visible app was created by a patient with long COVID. It's instead of a fitness tracker, a pacing tracker that can really help give some objective data to the patient. It's almost like Weight Watchers, where you get points for every activity you do. And okay, I got 14 points. Maybe taking my dog for a walk was 4 points, and now I got 10 left. It's kind of really practical for patients who like that information or have trouble doing this intuitively. And then there's a lot of different worksheets about pacing. I know University of Washington has a whole workbook from a class they do. This is ours that have kind of look from Bateman Horn and other good resources that we try to compile. But I do think that can be transformational for a lot of people. The last thing I'll just say, kind of within that, if managing energy, not crashing, is the baseline of treatment. But if patients really have severe deficits and enough energy that they can devote to a intentional rehabilitation program, I do like to refer them to professionals focused on that domain, whether it's physical, cognitive, or mental health. Those all drain the battery. And especially if you can find a provider who has experience with long COVID, because these have to be titrated to what they can handle. Physical therapy is a little controversial. If it's too much, it can be harmful. Same with kind of cognitive therapy, or even doing an intensive PTSD program can actually cause post-exertional malaise. But if it's titrated right, I don't think these are curative, but it really helps refine those energy management strategies, build on patient strengths and augment their weaknesses, and hopefully, in the best case scenario, push that wall a little bit farther away. I think of patients, they have a lot of young and active patients who really want to exercise again, and it is hard for them not to be able to do that. But once again, in the practical sense, I agree with patients that we should avoid traditional graded exercise. It can cause post-exertional malaise and be harmful. But if patients are in a spot where they think they can do some activity, really starting low, trying to break that cycle of deconditioning, I tell patients, do very small, whether it's 10, 15 minutes. On a good day, it's 10, 15 minutes. On a bad day, you just forgive yourself and save that energy for the next day. But trying to do it consistently can really help. The body thrives on routine. And from patients I've heard, who want to do a little bit more physical activity, the three major stresses to the body that I've heard over and over are heat and dehydration. I think that's the autonomic dysfunction and that vasodilation. Patients have little reserve. It's hot in Texas, so you got to work out inside. The orthostatic stress, kind of, doing lunges or burpees or yoga, going up and down can really be hard for patients. And if they have a lot of autonomic dysfunction, I actually counsel that they start physical activity recumbent, laying down. And I think that high impact, like running, jumping, interval training, just knocks people out. And so I'm really counseling them to try to do stationary bike, bands, or something that's a little bit more gentle on the muscles. And I will say, just practical advice, the one exercise that eliminates all of those stresses is swimming. So if patients love swimming, I do think that's a fantastic place to start to get some aerobic activity without potentially or in reducing the risk of experiencing post-exertional malaise.
I think what you said about recumbent exercise is very important to reiterate to patients. The other thing which, just speaking with physical therapists is Pilates has more than even yoga. Exercising just small muscles at a time is sometimes also very helpful. And I loved how you explained pacing and energy conservation. So there was a lot of learning in those slides. Go ahead, Nick.
So in terms of those patients who maybe aren't able to successfully control their post-exertional malaise with pacing, what are kind of your first line approaches for managing patients with maybe significant fatigue or these kind of exacerbations or flare-ups?
Yes, I think it's a great question. The I'll answer that a little bit. So the first two steps, and I'll share the slides. Um, you know, I think if patients are not having a functional recovery that they want with energy management, intentional rehabilitation, um, or they just have such a severe symptomatology. I'll kind of skip a little bit here. I do move into the third step, which gets a little bit more into the medical. And I agree, for those patients who just can't get out of bed or just not getting the recovery they want, it's you moving more into the pharmacologic management, or for the really severe ones, trying to get them involved in clinical research, clinical trials. For the symptomatic management, for physicians, I kind of, this is really symptom driven. So I try to see, kind of the rubric. Well, what's your worst symptom? Is it the fatigue? Is it the cognitive dysfunction, nerve pain, insomnia? And I will prescribe a med uh, focused on that. Um, Obviously, avoiding sedating meds. If it's nerve pain, I try to avoid gabapentin. I think my go-tos tend to be a little bit more of the activating medications, which tend to be more of the psychotropic meds. We found that bupropion, amantadine, I try to use them third line and sparingly, but low dose stimulants can put some juice in the battery, as I explain to patients, but I always do caution them that they do not make that wall go away. So if you take a medication like bupropion, low dose methylphenidate, and the patient gets 30% more energy and concentration, but they try to do 50% more things, it actually becomes counterproductive. I just tell them to do 25% more activity and bank that 5%. Once again, I cannot make that wall go away. I'm always trying to treat the comorbidities that we identify with the autonomic dysfunction, POTS, obstructive sleep apnea we found in a lot of people. So trying to get them in the best physical shape possible, making sure their diabetes are controlled. But this is a little bit, this gets very individualized based on the symptoms that are most functionally limiting for the patient. And if that is still hard for them, I think PCPs are probably not going to do this. This really needs more of a specialized center, but if they have just such a severity that they are not benefiting from these first three steps, is where I'm trying to get them into more of the targeted therapies. Those main categories, I would kind of say, focused on viral persistence, although the initial antiviral trials have been negative. I think other therapies towards immune dysregulation. Our center, we've been interested in IVIG and kind of the autoimmune phenomenon of this, although that is wildly expensive and inaccessible and still in clinical trials. But I think the one that we do have embraced is low dose naltrexone. I'll say a note, it doesn't seem to help every patient, maybe 50 to 60% of patients, in a pattern that I can't quite predict. But the safety profile is really favorable. So even though it is off label, compounded medication, I do think the benefit and safety profile is favorable enough that we do prescribe it. Although I know it's some mixed. I do think there's some evidence looking at mitochondrial medications, hyperbaric oxygen, trying to address the endothelial dysfunction. But that really, if symptomatic management becomes individualized, the talking about targeted or curative therapies based on preliminary or theoretical evidence becomes a long informed consent. I would say, the ones our center uses the most are probably low dose naltrexone. We've had some experience hyperbaric oxygen. There's a lot of facilities that provide this locally in Austin and even EECP, although that gets quite expensive. And I am particularly interested in a lot of the clinical trials of this immune dysregulation, but the safety profile of those and expense, I think, is going to really limit them to clinical trials from now on. So I'll stop there.
So, Mike, my next question was about POTS and autonomic dysfunction. And, that's something that becomes like a maze for primary care physicians. They're not very familiar with POTS or orthostatic intolerance. What simple assessment techniques and interventions can they do right there in the clinic?
Yeah, it's funny. So when I started doing this 4 years ago, I was telling patients, I'm not a POTS specialist. And then this has become so common that one day I was like, I got to stop saying that. I own this now, and kind of become a POTS specialist. So I'll just say POTS, kind of tying it back to the post-infectious chronic condition, it is a heterogeneous syndrome, which can be a multiple pathophysiologic mechanisms of autonomic neuropathy, which I think probably long COVID, that is the most common phenotype, but also hyperadrenergic state. It is commonly comorbid with other connective tissue disorders or hypermobility states like Ehlers-Danlos. And even before COVID, people were saying this is likely a post-infectious autoimmune process affecting younger people. So there are a lot of overlaps. I think to answer your question, how should we screen for this? If patients have any sort of orthostatic symptom, dizziness, tachycardia, I think all patients you suspect have long COVID should be screened for this. But if any of those symptoms, you should absolutely do it. And I'll just here's what I use. It is very hard to do a 20-minute Massillene test in clinic based on the staffing resources, the time it takes, and patients don't love doing that in 20 minutes. So here's my handout. I actually have patients do this at home. It gives them the instructions, and there's even a YouTube video that patients can follow along now on this handout. That basically we give a little bit more of a simplified Massillene test. So we have them measure their heart rate and blood pressure laying down, sitting, standing up after 5 and 10 minutes. And I think that actually gives me a ton of really accurate information that doesn't necessarily formally establish the diagnosis, but I think it's clinically useful enough to take the next steps. And the reason for this is I've had a lot of patients go get a formal tilt table test, and they were like, I actually felt good that day. I wasn't that symptomatic, or the results were equivocal. Then I have them do it at home, and I tell them to do it on a good day or a normal day for them, kind of at their baseline, but then do it during a period they're highly symptomatic. And the results have been striking that really in their home environment or their typical or bad health, how many patients we've identified have POTS, even if some of their clinic or tilt table testing were normal. I think there's a little bit of in the autonomic community, a debate of, do patients with long COVID and POTS have POTS all the time? And I think I would probably say in my experience, the answer is no. If they're doing okay, they may not, but if they are highly symptomatic or experiencing post-exertional malaise, they will likely have POTS. And so the timing of the testing can be very important. And this is a tool I've tried to make as patient-friendly as possible. There's a table they can fill out. I just say, take a picture, upload that picture to the portal so I can review and we'll talk next steps. And so I'll also say on that one, this may be a little bit beyond primary care, but in the specialty realm of long COVID clinics or a neurologist. But we have also found that a large group of these patients have small fiber neuropathy. This is some old published data, our own internal clinic data that we are publishing. We found about 55% of the patients have neuropathic pain, and in about the 90 skin biopsies we've done for small fiber neuropathy, about 2/3 of those patients, so 60, end up having small fiber neuropathy. Those are the smallest nerves that control both sensory and autonomic function, and they are very susceptible to changes in blood flow or energy. So it kind of falls along with that either autoimmune or endothelial damage associated with long COVID. And then if we do identify patients have autonomic dysfunction through screening for POTS or orthostatic hypotension or have a lot of dysmotility, those are honestly the most symptomatic and severe patients. So sometimes you are involving multiple specialists. But I do think starting POTS management with the non-pharmacologic measures of electrolyte and fluid intake, compression, recumbent exercises if they can tolerate it, and then maybe some beta blockade, pyridostigmine, ivabradine seems to work very well at slowing the heart rate without the systemic effects of beta blockers, although ivabradine is quite expensive and technically that's off-label, although those trials are ongoing. But I think that's a place to start. But if you are noticing patients have multiple systems affected that can kind of have the common connection of autonomic dysfunction, think about treating it comprehensively with a specialist. But certainly PCPs can kind of start that process or having these pearls in the back of the mind because they're likely going to be the most highly symptomatic patients.
Go ahead, Nick.
Great, thanks. So when it comes to cognitive dysfunction or brain fog, how are you approaching evaluation and management in the primary care settings? And along with that, are there ways that you help kind of differentiate or toe the line when a referral is needed versus reassurance and just kind of monitoring the symptoms?
Yes, it's a great question. And like all things long COVID, I wish I would say it's getting easier, but as everybody's had COVID and reinfections, getting older, this is getting hard to sort out. So the pearls, I think, how do patients explain this? It is usually brain fog, trouble focusing, forming thoughts, thinking clearly, remembering. It is, I think, people describe it as a fog. Um, the research has really demonstrated that major cognitive impairments are rare. So I do think doing a MoCA is a great starting point. Our data shows that usually, patients are somewhere in the 20 to 30s, that they may have some minor deficit that would meet the definition of mild cognitive impairment. But if it is pretty profound, that makes me think like maybe something else is going on, because really what we're seeing in the research and in my experience is that the long COVID deficits are really problems of attention, concentration, and processing speed. So patients tell me my memory's gone, but really it's kind of like they walk into the living room, don't remember what they're doing, or they meet somebody at a party, they say, my name's Joe, right over their head. They're having trouble finding words while they're giving a presentation. And I'm not a neuropsychologist, but a lot of people describe that is not actually a memory or recall problem. It's really a lot of times a concentration and attention deficit, or just they have less facility processing different or just making connections and processing. And those things are important for executive function, but I think it comes out a lot when patients are having conversation, because you have to pay attention to what people are saying. Think about what you're going to say. It's actually a very large cognitive lift to have a coffee and talk with someone. And so I kind of put it in the pattern of, if that's kind of, you dive a little bit deeper under the surface of what do they mean, how does it affect them, if that fits that pattern, I would say that is consistent with the neurocognitive dysfunction of long COVID, especially once again, if it is associated with the fatigue, that when they're fatigued, the brain fog is worse, or if they experience post-exertional malaise from cognitive exertion. I think that is like the classic pattern that really makes me think this fits into long COVID. You know, if it is profound deficits that they don't recognize people, they are getting lost in their neighborhood. I've seen a couple of those that maybe are long COVID, but that really starts to make me think potentially dementia or another chronic degenerative disorder. Although, I think there's a lot more research going into this place. We are seeing cortical volume loss on a population scale, which is being attributed to COVID, loss of IQ points. But I do think neuropsychology and speech language pathology are very limited resources, even here in Austin and probably across the country. But I think if you're like, boy, this seems like it's more than concentration, attention, and processing, or this is profoundly affecting their ability and functioning, and they may need even disability protections, getting that formal assessment can be helpful. But what we're doing a lot for people who kind of fit the more classic pattern is we're kind of linking it to the energy management, the intentional rehab, or what are some accommodation strategies of helping with executive function, note-taking, structured problem solving, before, once again, if it is very severe, we'll think about some of the ADHD medications, usually the non-stimulant off-label options like bupropion, amantadine, but we will move into I don't love, we're trying not to be a stimulant clinic, but I have found for some people with the severe symptoms that low doses can be particularly helpful if used appropriately, although once again, really individualized for that. And then I just say for the cognitive dysfunction, don't forget pseudo dementia. Don't forget, their perception or deficits can be pretty severe, and you don't want to miss substance use, mood disorders, and even just connecting them to a long COVID community to validate their concerns, to have other patients give them practical tips, we found to be really validating and helpful as they navigate, what is the invisible illness of long COVID. So it's kind of we throw a little bit of everything at patients going through that.
Yeah, I think this was so valuable. Two things that I just want to reiterate, what you said. One is sleep. A lot of them we see have a new diagnosis or worsening of pre-existing sleep apnea. So that is something just to keep in the back of your mind. These patients often will have overlapping sleep apnea. And the second thing is that chronic fatigue and the brain fog will go hand in hand. And if they are very tired or overdoing things, going into a push crash cycle, then brain, the cognitive function will also decline. So a lot of times the cognitive, slowing or dysfunction is also a function of their fatigue itself. They're so tired that they cannot think clearly as well. Thank you so much, Mike, for this very wonderful and insightful conversation, and also for the practical tips. I think that you shared with us very impactful pearls that primary care physicians can use in their daily practice. And I feel more comfortable about, especially about dysautonomia. So thank you very much for giving us time today. This was very, very helpful. This will be recorded and shared on the ACP website for folks to watch later on as well. And if anyone has questions, we can ask Dr. Brode. Otherwise, this has been such a pleasure and an honor.
Yeah, thank you so much, and thank you for the invitation. really appreciate people coming out for such an important topic.
Thank you, Mike. And hopefully we will, towards the end of the year or something, we will hope to hear about your next very impactful and exciting project that you are going to be doing in your long COVID clinic. So thank you very much.
Thank you.
Thank you, everyone, for joining us today.